Today's Royal College of Surgeons of Edinburgh webinar, which today is about incisional hernias by a good friend and current colleague of mine, Mr. Bignell, who's an emergency and colorectal surgeon and comes with a wealth of experience about complex hernia management as well as abdominal wall reconstruction. I'm really looking forward to hearing what he's going to say about incisional hernias. Just to remind everybody, Tuesday the 1st of September, which will be the next webinar, is on the management of gynecomastia by Dennis Ramundes, who's also one of the breast surgeons from here in Oxford. So there's a plethora of Oxford surgeons giving these webinars, which is good to see. But for the moment, I'm going to hand you over to Mark Bignell. There will be a chance to ask questions at the end, but please, if you have any questions, use the Q&A button at the bottom, and I'll try and answer them as we go along. All right. Mark, over to you, old boy.
Thank you, Giles, for that introduction, and welcome everybody to today's webinar. So I'm going to talk to you about incisional hernias. This is a pretty broad topic to speak on. There are textbooks that tell you just how to operate on these patients. So I'm going to try and keep it light and try and give you some of the key facts that are going to help you in your early surgical careers. We'll go over what a hernia is. This is a favorite exam question. And then we'll talk about why patients get incisional hernias, how they present, and then how do people such as myself and Giles decide who to operate on, what we do try and do when we operate on them, and then what happens when it goes wrong. So I think first and foremost, you all need to have a definition of a hernia in your head. An abnormal protrusion from one anatomic space to another, where the protruded parts generally contained in a sac-like structure formed by the membrane that naturally lines the cavity. That's quite a wordy definition. And in the case of abdominal wall hernias, so not just incisional hernias, but all abdominal wall hernias, the protrusion is through the abdominal wall. And you're talking about a sac-like structure that's actually the peritoneum. And it's summed up quite nicely on this diagram here. You'll see the layers of the abdominal wall. And you'll see in the center there, that pink structure is the bowel herniating through. The blue line is the peritoneum. And as you can see at the point of the hernia, it envelops the small bowel and is what we term the hernia sac. And then above the hernia sac, the fascia and the muscle have parted, and all that's left is the subcutaneous tissue and the skin. And that in essence is a hernia. When we're talking about hernias, it's important to talk about the terminology. And the key diagnostic feature of a hernia is the fact that it's reducible. And what that means is that the hernia can be gently pushed back into place or that disappears when the person lies down. And this is key. If a patient describes a lump in the abdomen that has this feature, you can almost be 100% certain that it's a hernia. And an irreducible hernia is essentially the opposite of that. So it cannot be pushed back gently and it cannot disappear when the patient lies down. When we talk about irreducible hernias, we then go off to start talking about obstructed and strangulated hernias. An obstructed hernia is one where the bowel within the hernia sac is trapped and therefore obstruction of the bowel occurs. The key point here is that the bowel itself is viable. Whereas in a strangulated hernia, the contents of the hernia sac, and this may be bowel, this may be omentum, this may be bladder, are ischemic or not viable. And this needs urgent operation to try and salvage what is left of the contents and to make the patient better. Notice that I've not used the term incarcerated. Incarcerated is used interchangeably with irreducibility, but over my years, I've found that incarceration tends to get confused with strangulation, and it tends to cause more confusion than it actually helps when describing a hernia. So I tend to stick with reducible and irreducible. And if a hernia is irreducible, is it obstructed or is it strangulated? We'll just look at the abdominal wall anatomy. I don't want to spend long on this. I think most of you are probably are aware of the abdominal wall anatomy and what makes it up. But it's a fibromuscular cylinder. And in the center, there are two muscles enveloped in fascial sheath that form the rectus sheath, both anteriorly and posteriorly. This fusion of overlapping muscles helps to support the abdominal wall. And at any point, if there's a weakness there, then an incisional hernia will occur, or any other type of hernia in the term of inguinal hernias or epigastric hernias. An appreciation of this anatomy is key, as we'll see later on in the talk when we talk about where we place meshes to fix hernias. So how do hernias occur? Well, all abdominal wall hernias develop with the same pathogenesis, and that is the fact that the abdominopelvic cavity is a cylinder and it's enveloped with muscle and bone. And this muscle, when there's any generation of pressure within the cavity, contracts to form counter pressure. And there's a balance between the two, which means that the abdominal wall contents don't spill out. At a point of weakness, and this may be somewhere like the inguinal canal, the deep ring, or through an incision, then a hernia will form if there's continued intra-abdominal pressure that's greater than the counter pressure developed by the abdominal wall itself. And once this hernia is formed, then it will continue to enlarge as the pressure increases. And the rate at which this increases depends on a number of factors, which we'll discuss. From an incisional hernia, therefore, it can occur anywhere where there's an incision. And I think this diagram neatly shows the different types of incisions we use. Some incisions are more prone to incisional hernias than others. But as you can see, an incisional hernia can come anywhere in the abdominal wall. And this makes them a challenge to repair. This CT just gives us an example of incisional hernia. This is somebody who has had a previous stoma reversal. And as you can see, you have the abdominal wall shown on the CT, and bulging through it where the arrows are is the hernia with the small bowel content. The hernia itself is obstructed, that small bowel's dilated. And this is an obstructed hernia that needs urgent fixation. So why do incisional hernias develop? Well, there are a number of risk factors, and obviously open surgery is probably fundamental in their development. They do, however, occur with laparoscopic surgery. They can occur at the site that we've placed the ports, and they can also occur at the small extraction site. But by far and away, it's more common with open surgery, and it can occur in anywhere up to 10 to 15% of patients who undergo any form of open operation. And a midline incision is by far and away the most common site for an incisional hernia to develop. If we were to look at a paramedian incision, so that's an incision through the rectus muscle in a longitudinal plane, compared to an incisional hernia, that's 3 times less likely, compared to a midline incision, that's 3 times less likely to form an incisional hernia. And a transverse incision is less likely again than a midline incision to form an incisional hernia. And that's because you're dividing through fascia and muscle, and the muscle closes over the fascia, and this allows the abdominal wall to heal better. The midline incision is difficult to heal because it just goes through that linea alba. There's no muscle there. So if that gives and that linea alba doesn't heal, then a hernia forms and there's no other supporting tissue. So you might ask, why do we do midline incisions then? Well, the advantage of a midline incision is it gives you access to the whole abdomen. So in the emergency setting, in the colorectal setting where we need to perhaps be in the left and right upper quadrants if we're mobilizing flexures, it gives you access to the entire abdominal cavity, but it's at a price. It's not just the incision, patient factors also play a part, and obesity is by far and away the biggest risk factor for the development of an incisional hernia. And anybody with a BMI of over 33 is at a high risk of developing an incisional hernia post-operatively. Smoking, due to the nature of smoking itself, but also the fact that it causes patients to cough and therefore raises their intra-abdominal pressure, is again another risk factor. As is previous surgery, as you can probably imagine, if you've had 3 or 4 incisions through the midline, you're left with a lot more scar tissue, and that's harder to heal. Surgical factors also play a part. By far and away, wound infection is the major contributor for incisional hernia development. And it's felt in some papers that if you have a wound infection in the midline, you probably have a 25% chance of developing a hernia there at a later date. We talk about suboptimal closure, and it's key for the surgical team that are closing the abdomen to make sure they oppose the skin and the wound edges and the fascial edges, that they don't pull the stitches through and develop ischemia, and that through the midline, if we can, we have good exposure and a mass closure. The type of abdominal surgery also plays a part. Colorectal surgery, because of its inherent nature for wound infection, it places patients at higher risk for incisional hernia, and so does vascular surgery, typically aneurysm repair. This is probably due to the length of the incision needed, but also due to the disorders of connective tissue associated with aneurysm formation and hernia formation, and there's good correlation between the two. So how do these patients present? Well, electively, they often present via their GP as a reducible lump that they may have just noticed that may be symptomatic with a degree of pain. And we know it's an incisional hernia because there's a scar over the top of the lump itself. They may have had features of obstruction, but have never had any issues with irreducibility and full-blown obstruction. They may also present as an emergency with an obstructed or strangulated hernia. This is often on the background of having known that they've had a hernia for a number of years, and some may even be awaiting surgery. If there are skin changes or the hernia itself is extremely tender, then these are signs of strangulation. The differential is that for any other lump, and if there's any difficulty in making a diagnosis, then a CT of the abdominal wall is the best way to image the hernia. This gives us an idea of both the size of the hernia, but it also allows us to know the contents, whether there's any other hernia present, and allows us to plan surgery if needs be. So when do we operate? Well, electively, we tend to operate on anybody who's symptomatic and where the hernia is either interfering in their activities of daily living or is causing sufficient pain for the patient to feel they want to undergo surgery, and where we think repair would be of benefit to them. If the neck of the hernia itself is narrow, then that tends to prompt us towards surgery because there's a greater risk of obstruction and strangulation. And if the patient has symptoms suggestive of obstruction, again, that's a sign that the hernia probably should be fixed sooner rather than later. But before we rush in, it's important to correct any of those adverse factors that we've mentioned that place you at risk. And as a way of example, if we look at patient A, who's a diabetic with poor control and a smoker with a high BMI, his risk of complications from an incisional hernia repair are almost 40%. If you took the same patient but corrected his diabetes, if he stopped smoking and he managed to lose weight to a BMI of 30, you can reduce his risk of complication from an incisional hernia repair down to 9%, which is, as I think you will probably agree, quite a significant decrease. And so before we operate on people, we have to optimize them the best we can within the confines of what they can and can't do. But ideally, their diabetic control must be remedied. They must give up smoking, and they must lose weight. As an emergency, we don't have that luxury. And really the mainstay of treatment in the first instance is to resuscitate an image so that we can understand what we're dealing with. If the patient is obstructed, they will need an NG tube and IV fluids, as I'm sure you're all aware. And then at an appropriate time, they're taken to theatre. If the hernia is strangulated, that whole process is sped up. And we like to get them into theatre within 6 hours to try and prevent further deterioration of the hernial sac and its contents. The priority in emergency surgery is actually to relieve the obstruction and to make the patient well again, and it is not to repair the hernia itself. If it's felt appropriate, then a mesh repair will be done as an emergency, but often we will just repair them with sutures, knowing that there's an almost 100% chance the hernia will recur, but this will buy us time to get the patient in a better condition to allow us to do a more thorough fixation with a lower chance of recurrence. So how do we fix hernias? Well, if the defect is small, many years ago it used to be less than 2 centimeters. The European Society for Hernias has now dropped this to 1 centimeter. Then a primary closure with a suture is more than adequate. That's a very, very small number of hernias that we see, and therefore we'll be placing a mesh. There are a number of ways you can place a mesh, and there's a number of papers that have looked at the different outcomes, and these are shown on the table to the right. But essentially, an onlay mesh, where the abdominal wall is closed and the mesh is placed on the top, and an inlay mesh, where the mesh is placed within the defect and the defect itself are not closed, are both found to be poor techniques and are no longer used unless in exceptional circumstances. And as you can see from that table, they have a significant complication rate and a very high recurrence rate. So what we tend to do now in the open setting is a sublay repair, and that's picture B, or the second one down. And in that, we create a plane behind the rectus muscle. If it's not in the midline, if it's over to one side, then we'll make a plane between the various external and internal obliques and the transversus abdominis. And that will allow us to place a mesh, and then we will close over the top of that. The advantage of this is that as the intra-abdominal pressure rises, the abdominal wall can contract and it's reinforced with the mesh rather than the mesh being placed on the top or in the middle, whereas the intra-abdominal pressure rises, the mesh just gets pushed off. If laparoscopic repair is contemplated, then we tend to do an underlay mesh. This works in exactly the same way as a sublay, but does require the fascial defect to be closed. If the fascial defect is not closed, it acts in no difference to an inlay mesh, and the recurrence rates are high again. But as you can see, sublay and underlay meshes have a low recurrence rate. The risk of needing the mesh removed is low, and they are certainly the standard methods that we should all be using and the standard techniques. And this here just gives you some ideas of the meshes that we use. On the left, we have a synthetic mesh, and these are made up of any number of different materials. Some are permanent and are there and are incorporated into the body tissue. Some are, such as a vicryl mesh, dissolve. And these are the mainstay of meshes. They're cheap and they're reliable. On the right, we tend to use the biological meshes. This one, I believe, is a permacoal mesh and is made of pig skin that's treated and is biologically inert, and so it doesn't excite a reaction. And we use these when we're trying to bridge large defects and close large hernias, and we're concerned about the presence of infection, or we're concerned about placing the mesh itself onto bowel. If you place these synthetic meshes onto bowel directly, the bowel will adhere to it. If you're lucky, that's all it'll do, but more likely it will fistulate through, and then your mesh will get infected with bowel content. There is no evidence that biological meshes are any better than synthetic, and more recently there's been a drive to use synthetic meshes further and reserve the biological meshes for the more complex type of hernia repair. When we talk about incisional hernias, we have to think about stomal hernias and those sitting around big parastomal hernias. And this mesh here on the left has a hole cut through it. And what this allows us to do is to pass the bowel through it to repair the stoma, or to allow the stoma to continue to be formed, but the defect to be repaired. Next to it is an intra-abdominal mesh. This one has a coating on one side that stops the bowel adhering to it. And these are commonly used in laparoscopic procedures that allow the bowel to sit up against the mesh itself without causing the risk of erosion and fistula. So finally, we'll just move on to the complications of surgery and what sort of happens in the long term. By far and away, the most worrying complication for hernia surgeons is that of a wound infection. These occur in about 5% of patients, but predispose you to recurrence. And then they go on to form mesh infections as well. A mesh infection probably occurs anywhere between 2 to 7% of incisional hernias, dependent on the size of the incisional hernia. Mesh infections can be treated with antibiotics, but they're difficult to treat because they're biologically inert and the bacteria adhere to the mesh and form a film that the antibiotics can't penetrate. And therefore, in most circumstances, if the mesh gets infected, it will often need to be removed or explanted. When you do that, you're essentially giving the patient back a hernia, and therefore further reconstruction will be needed. And this is sometimes a role for the biological mesh, and that's what biological mesh users will advocate. Sort of lesser, those are the sort of serious complications, but for the patient, actually things such as a seroma, which is a collection of fluid where the hernia was, and numbness to the skin can actually be quite distressing. Most patients also think that after a hernia repair, they're going to have a normal flat abdominal wall. And it's very important to temper these expectations. Whilst it's nice to have a flat abdomen, again, in most parts, that's difficult for us as hernia surgeons to achieve. And what we actually want to try and achieve is a good sound fixation that allows the patient to return to activity without any further recurrence. And finally, I mentioned pneumonia and PE. Hernias are, incisional hernias on the abdominal wall are very painful post-operatively, and it's important to make sure that the patient's analgesia is optimized so that they're able to ventilate properly. If they can't take a deep breath because of the pain from the dissection and the hernia repair, then they're predisposing themselves to pneumonia. And if they're a smoker, that increases that risk. And it must be mentioned that when we do an abdominal hernia repair, especially an incisional hernia repair, what we're doing is we're tightening up the abdominal wall. So we're making it harder for the abdomen to relax. We're making it harder for the diaphragm to be able to push down. So that splinting of the diaphragm combined with the pain makes these patients at a real risk of pneumonia. What about long-term outcomes? Well, recurrence rates actually for primary ventral hernias, so not for incisional hernias, but for an epigastric hernia or an inguinal hernia, at 10 years are somewhere in the region of 37%, which is reasonable. If you look at an incisional hernia, though, you've got a 64% chance of it recurring within 10 years. And for multi-incisional hernias, so somebody who's had a number of incisions or has got 2 or more hernias within the same incision, that risk goes up to 73% at 10 years. So it's by no means a guarantee, and patients need to understand this. They also need to know that it's a big operation and the benefits do need to be there before we contemplate surgery. And this isn't impacted by the mesh we use. There's no evidence to suggest that a biologic mesh is any better, but it is impacted by surgical technique, and it is impacted by the ability of the surgeon and the number of hernias they do. It's important to get it right because redo hernia operations are even harder. And as I've said, that their incisional rate and recurrence rate is dramatically worsened. It's important to have a definition of what a hernia is. And incisional hernias are best avoided, and this can be done by avoiding midline incisions where possible, by selecting patients before surgery and optimizing them, making sure they lose weight, making sure they don't smoke, and try and adjust all of these risks, and then employing good surgical technique at the initial time of surgery to close the abdominal wall properly. If they do go on and develop a hernia, then it should be with a mesh, and it needs to be done in the right patient and by the right surgeon who is skilled at doing these incisional hernias. And finally, I'll just leave you with this picture here, that not all incisional hernias are created equally. The 2 pictures on the left and the middle are a gentleman who's had a number of operations, and he's actually had a laparostomy, and that's why he's got that redness in the middle part of his wound. And that sort of irregular feature you can see is skin with bowel sitting underneath it. So he has a huge defect, and you can see from the lateral, from the side view, that this is a huge defect that we've got to put back in, and is going to require a major operation to fix. This is not a quick incisional hernia repair. And the chap on the left is a guy who's got a parastomal hernia. And I think you can see that that is a reasonable sized hernia, and just popping that in with a small bit of mesh and telling him that will be fixed with an hour's worth of operating is not in any way feasible. And this is what we term complex abdominal wall reconstruction. It's not the same as an incisional hernia. We're not going to talk about it today because it's another huge topic, but it's just to make you aware that not all incisional hernias are the same. So I thank you for your time, and I welcome any questions that you may have.
Oh, that's fantastic. Thank you. Thank you very much indeed. Really, really appreciate it. There are quite a few questions, actually. They're all along a similar theme. If I could just go through some of them. So when you repair some of your big sort of midline incisional hernias, can those hernias cause abdominal compartment syndrome, ACS? And if it can, what can you do to mitigate?
So yes, it can do, is the short answer. And at the time of surgery, there's very little you can do to mitigate that if you want to close the abdomen, because if you pull the abdomen closed with the mesh and then close the fascia over it, and then they develop or have difficulty with ventilation at that point, there isn't anything you can do. You don't want to start doing releasing measures laterally, because that just deteriorates the abdominal wall out to the side. So actually the key is to try and predict this before the operation. And we can do that by looking at the CT. I didn't want to go too much into complex abdominal wall, but we talk about loss of domain, where the abdominal cavity is actually smaller than the hernia itself, and so there's no way that's going to be put back in. So what people try and do is they give something called Botox preoperatively, usually 6 weeks or so, and that relaxes a lot of the musculature, and it allows the abdominal wall to come together more easily. The other thing you can do is you can do a staged repair. So you put a mesh in, and it allows the abdominal wall to come together in part, and then you take the patient through theatre a number of times to try and then bring the abdominal wall together. But it's important to try and recognise this early on whilst you're working the patient up, because trying to do this at the time of surgery is a disaster.
Well, and sometimes, quite frankly, impossible. If you do manage to bring something together, do you think it's better to close as a continuous suture or as an interrupted suture? Or actually, in my opinion, does it matter? It's about how good you do either of those. What are your thoughts on that, Mark?
I mean, there's a lot of talk about interrupted sutures, deep tension sutures. Personally, I'm with you, John. I don't think it matters how you do it. I think you need good bites of tissue that are well spaced apart, and it must be done without tension. And I think that's probably the key. I think when I see a lot of the junior trainees closing, they've almost got their foot on the patient as they're pulling the suture through to try and bring the abdominal wall together. It just needs to be opposed. You're relying on the strength of the suture for the first 6 weeks, whilst the abdominal wall opposes and knits itself together, and then that takes over. So you need the right suture material, but you just need to bring the abdominal wall together without tension.
Yeah, I agree, Mark. We've got time for one more question. There are people desperate to know, and if you're able to, I know it's difficult because it's quite a complex understanding, but can you just briefly explain what you mean by sort of component? They're using the word compartment, but actually it's component separation. What does that mean very briefly? Because I appreciate you could spend a day talking about that.
So when we tend to fix an incisional hernia, what we do is we separate the various layers of the abdominal wall to create a pocket. And what we want is to be able to close those layers with a mesh in between. Sometimes the defect is too big to allow that. And so what we do is we separate parts of the abdominal wall to allow them to move further. But that's at the risk of compromising the abdominal wall laterally. So the classic one is an anterior component. And what you do is you divide just past semilunaris, and that brings the rectus over to the midline further. But what that does is it weakens the abdominal wall on the outside. And so it's a technique we use to close big defects in combination with a mesh and the standard inlay mesh that we use. It's a technique that we do to bring everything across. It's an advanced technique. It's not needed for most incisional hernias. It's only really those last pictures I showed in patients like that where they need to be used. And it's not something that should be done by a surgeon who does a hernia every now and again. It needs to be done in a specialist centre by a surgical team who know what they're doing.
I agree. And I think that if you're being asked, even up at FRCS, if you're being asked about that kind of level, I think you've really passed the exam already. That is super specialist surgery.
And I think you and I will agree, Giles, in our practice, the number of patients that we have to do compared where we need to do component separations and things is small compared to the number of incisional hernias that we actually see as a surgical group. And that's why I've stayed away from that today, because that's a minutiae, really. I mean, that's super complex work. Understanding the fundamentals of a basic hernia repair, I think, is key.
No, it's look, Mark. Thank you so much. I'd like to also thank the Royal College of Surgeons of Edinburgh for putting together these fantastic webinars. Mark, you've excelled. I've enjoyed listening to you. It's been brilliant. Thank you very much.
Thank you.
And I will just remind everybody: 1st of September, gynecomastia, management of gynecomastia. It's one of those questions that does come up in exams. So please, I look forward to tuning in, everybody, and I'll see you all then. All right, take care.